Hey guys, good to see you.
Hey, good afternoon.
Good afternoon.
Back in Chapel Hill, I've been traveling a lot for work lately. I came back and my wife bought a fish while I was gone. It's like every time I leave town, we have a new dependent.
Is it like a complicated tank or like a simple goldfish situation?
It's in a bowl. It's no salt water, fresh water, little beta fish. I give it 48 hours life expectancy.
The first time you try to change the water, it's going to escape.
See if I can keep him away from my 3-year-old.
You better get a little shovel because I'm sensing a backyard burial soon.
That reminds me of the time I had a long day at work and I got home and we owned a cat.
Should we dive in? Yeah, let's do it.
Let's do it.
Paul, do you have the catchphrase today or?
I didn't.
All right, let's swallow the fish.
Welcome to HealthTech Remedy, the show where 3 physician leaders in health technology tell the stories of new and established companies and interview leaders from the industry. I'm Trevor Royce, radiation oncologist and researcher with experience in real-world evidence, informatics, and AI diagnostics.
And I'm Paul Gerard. I started off as a physical medicine rehabilitation physician before focusing on reimbursement policy, molecular diagnostics, and market access for AI products.
And I'm Tim Showalter, a radiation oncologist and prior med device entrepreneur who is now focused on bringing AI advances to cancer patients.
This week, we're diving into Isaac Health, a company rethinking how we detect and manage dementia and brain health. And we'll be joined by 2 guests, the co-founders, Julius Bruch and Salinas.
Isaac Health is building virtual-first interdisciplinary care to tackle Alzheimer's disease and related dementias, a massive and growing challenge for patients, family, and the healthcare system.
And we'll explore how their GUIDE model, standing for Goal-Oriented, Unified, Interdisciplinary, Digital, and Evidence-Based Care, is transforming access and outcomes in dementia care.
We'll hear from the founders themselves about how their backgrounds in neurology, public health, and healthcare consulting came together to address this urgent problem. It'll be interesting to hear about how they met each other and kind of got connected. I think they both have clinical backgrounds, but one of the founders particularly with a consulting background and kind of how they took off from there.
Isaac Health is a good example of technology-enabled clinical services model. I think we can talk a little bit about that overall business model and then focus on their specific clinical area and how they've responded to some of the available Medicare programs. They were founded in 2022, so pretty young company. Found online that they had an oversubscribed seed round of $5.7 million. Lead investors were Meridian Street Capital and B Capital. Other participating firms were Primetime Partners, Co-Found Partners, VU Venture Partners, and Air Angels. The founding area they're focused on is improving the function of patients with dementia and to make expert dementia care accessible to everyone. It's a virtual first clinic, but they integrate with brick and mortars health systems. And looking at their information, I think that their really main initiatives are this GUIDE dementia care model, and they partner with Medicare Advantage plans. And then they got some interesting resources for caregivers as well, and make sure that they're offering all the social and behavioral health services that are important as patients experience cognitive decline. So I think that, the idea is really connecting patients and their families where they are to make sure they've got all the right resources.
A critical component here is obviously the problem that they're addressing. And, a sort of common catchphrase in early stage investing is to eliminate weak founders and small ideas. Well, these guys are tackling basically one of the biggest ideas or problems in healthcare, and they're strong founders with pretty impressive backgrounds. Kind of think of the problem in terms of dementia or Alzheimer's and all the associated diagnoses that come along with that. It's kind of like cancer in that it literally impacts basically everybody with a family. And so when you're tackling a problem that touches everyone, it tends to be very bipartisan. Everyone's pulling for you, and you hope that you come up with a solution that can make it better. I mean, I know, at least in my own personal experience, this was before I was in healthcare, but my grandmother had vascular dementia, and it was just like so taxing and stressful on the family. Maybe more than any other diagnosis, even more so than cancer, maybe psychiatric issues would be a close second or tied. But like the just burden on those caregivers when you have dementia and struggling how to fit that in and the financial repercussions and the time, like there's just a lot packed in there. And if they can solve that, it's an amazing win for humanity.
A lot of the services people need are not like traditional medicine, and everything that you access is hard, right? You've got a loved one with dementia. And so every trip to the neurologist, like to get them out of the house and all dressed and ready to go must be a huge lift. And so if they can bring some of that into the home and make it easier to access and then make those connections that might otherwise be impossible to make if you're the caregiver. I mean, you got family and your other jobs. I haven't, had to deal with dementia in our family, but certainly have friends whose parents have had that. And just watching the amount of effort that goes into finding these services and accessing them is, it's pretty heavy lift.
For patients too, obviously as oncologists, that's bad enough, but then you have a patient that has a cancer diagnosis and then you layer dementia on top of that. I mean, wow, what a challenging clinical problem to deal with. And a cool thing about what they're doing is they have services not only to treat the condition, but also to support those family members.
They offer virtual care clinics for Alzheimer's disease and dementia, with the focus being on getting specialized expert care to the patient. Older adults, things like distance, getting to the clinics, geography can be a barrier. So by having these virtual care clinics, they can bring it to the patient. And it looks like they started before this CMS guide model, but in 2024, CMS put into place this guide model that they were really well positioned to start to take advantage of. The idea behind the guide model is that dementia care clinics can enroll in it and provide specialized care and support services for dementia patients and their families. Isaac Health, having already started up, having already thought about ways to implement this, was really in the right place, at the right time to take advantage of the new CMS program that enables a fresh payment pathway for this kind of thing.
So this was a new entity created by CMS, and my understanding is that it's pretty all-encompassing, right? So it's focused on improving outcomes for patients with dementia, but does it also include the caregiver support as well? Like it's the full package of this?
Yes. And so this is a model done under the Centers for Medicare and Medicaid Innovation. And it's a little different than a lot of the models we see in that the model is not for whole cost of care, but rather there is an expectation that there will be a package, sort of a suite of services delivered, this all-encompassing holistic suite of services delivered. And in exchange for doing that, the provider gets a fixed payment amount.
So this sounds a lot like an alternative payment model, basically. Is it fair to categorize it as such?
I don't know if it's the technical definition, but it certainly is alternative to the typical fee-for-service payment model.
Yeah. What I think is interesting is I do think this sort of scalability of a tech-enabled model like this, where especially like Joelle, I know is a big thought leader in the dementia space, to be able to make best practices available potentially in the home or at least at a local clinic that they've partnered with. I think it's really powerful because, as I mentioned, I haven't had a loved one need these services, but I have heard from people that when you even want to get initial like intake and testing done for dementia, they expect to wait several months to get in to see a neurologist. I think there's a shortage both of neurologists and neuropsychiatric who would perform the testing. So I think they're really, really addressing some important needs. And then to have it all sort of in one shop, I think is huge help for their family members. So I think that's to me what's the most exciting is kind of bridging that gap and using technology to do it. We've talked a lot about how partnering, whether it's just basic technology or like artificial intelligence with actual care providers and the clinical expertise is a great business model. And I think this typifies one that I think is poised to have a big impact. I think there's a couple of competitors in this space. So other names I saw are Harmonic Health and Bold, but it seems like they're also pretty early stage, like Isaac Health, pretty recently founded companies. So I think it's a good indicator that there's some opportunity to really improve patient care here.
One of the big takeaways is they are designed to be able to take advantage of the Medicare guide model. So it'd be interesting to learn how they are scaling with this and how they are making specialty, neurology and psychiatry or other dementia specialty care available to patients.
What I look forward to hearing more about is obviously they have deep clinical expertise. They're taking this tech solution to enable specialty care for this massive problem in healthcare. And it'll be interesting to hear about that implementation piece to a lot of what Paul was talking about earlier. Also, how you navigate changing regulatory landscape post-COVID with telehealth regulations coming on, coming off, and so forth. So I suspect they'll talk a little bit about that as well.
Stay with us for our interview with Isaac Health's co-founders, Dr. Julius Bruch and Dr. Joelle Salinas. We're thrilled to welcome Dr. Julius Bruch and Dr. Joel Salinas, co-founders of Isaac Health. Joel, Julius, welcome to HealthTech Remedy.
Thank you. Yeah, thank you. Happy to be here.
Happy to learn more about you guys both and also Isaac Health as well. Paul, do you want to kick us off?
Yeah, I guess we'd love to know just about you as people and your personal journey. What led you to found Isaac Health?
Hi, I'm Julius, CEO and co-founder of Isaac Health. My journey was, it involves a couple of steps. It started really with having a grandmother who had dementia. And I think that's an experience that I share with lots of people because ultimately dementia does affect 1 in 3 people. I saw firsthand just sort of how my family was going through this journey and process, and how we had to make many adjustments. First of all, it was really hard to get to a diagnosis in the first place. And I think that just reflects of the general lack of specialists here and how complex it can be to get to the right diagnosis, especially if it's not a standard form of dementia. And then, yeah, so really going through the grandmother moving into the home, moving into a nursing home, etc. So that really inspired me to go into medicine first, ultimately to also start training in neurology and doing my PhD in dementia. So my wish and dream was always to help people with dementia better and improve that journey. And initially, my approach was to do this through pharmaceutical innovation. But that's obviously a long process and complicated process. So after completing my PhD in that area, I actually moved to McKinsey, where I saw much more the health system side of this. I primarily worked with payers, so health insurance companies, and again saw the dementia problem from their perspective as of a vastly underdiagnosed and undermanaged condition. And that's sort of when I really, so what sparked the idea to start something like Isaac Health, and to really create a platform that can scale specialist care in this space. And that's how I reached out to Joel.
Yeah, and I'm Joel Salinas, and so I'm the Chief Medical Officer, co-founder for Isaac, as was mentioned before. And the way that I came to this, my family is originally from Nicaragua, first generation in the U.S. They came under political asylum, grew up in a very low-income household, and so I'm no stranger to having limited access to healthcare. Did all of my clinical training at Mass General and Brigham and Women's Hospital, was faculty at Mass General for a while, helped to found their Center for Brain Health, was its clinical director, and then in 2020 made the move to New York, where I became faculty at NYU Langone, continued seeing patients at the Memory Center and on the inpatient consult services. And all throughout, I've done a lot of research with the Framingham Heart Study to really understand the epidemiology of Alzheimer's disease and related disorders from a population health data science lens, as well as to understand psychosocial determinants of brain health. And at the national level, I work very closely with the American Academy of Neurology's National Brain Health Initiative. And 3 years ago, I got a cold email from Julius asking, would you be interested in starting an online memory center? I kind of took it as a sign from the universe. I'd been really staying up late at night, kind of years leading up to that, just really concerned about kind of our health system's ability to handle the huge influx of patients with cognitive disorders that are on the horizon. We often talk about the silver tsunami. And being in behavioral neurology, really working with individuals at the earliest stages with these conditions and all throughout, it was just very clear that there just aren't enough specialists in this area to manage the high patient load and the level of complexity. So whenever I would see new patients, the first thing that they would say to me is, you have no idea how long it took for us to see you. It started out being 6 months, 8 months, and then it became very clear it was about a year. Now I still see patients 1 day a week at NYU, and I'm booking out to 2027. And that is pretty consistent nationally across all the memory centers. The average wait time is about a year, and it continues to grow. And there have been really quantitative kind of forecasts done by groups out of UCLA and the RAND Corporation, really showing that in the next couple of years, we're going to be looking at 4, 5, and sometimes 8-year delays for people in particularly geographically isolated areas. And some are even showing that people who are dual eligible, who really need this kind of care, are going to have even longer waits de facto. And so to me, that's a huge public health crisis, to start to develop a disease process that is impacting your identity, your ability to function in the world, how you are able to even care for yourself and make decisions for yourself, and then be told that you have to wait a year or more to be able to find out what's going on and manage it is a real problem. And even more urgent because we have these, this amazing historic breakthroughs, right? Where we have these disease modifying therapies, these amyloid targeting monoclonal antibodies that help to clear amyloid plaque from the brain in the setting of Alzheimer's disease. But at the earliest stages, during a very specific window, and people will be likely to miss that window if they have to just wait to be seen. I mean, would be inexcusable in oncology, right? That you start to develop a mass or tumor, or that you get something identified, and then you have to wait a year or more to get treatment, because we know what happens, right? Within a couple of months to a year, you start to lose your ability to have an impact. And so this was like really what drove my decision to make the big scary leap out of kind of the security of academic medicine and a research career that was really doing quite well, and to start Isaac Health with Julius. And really proud of the work we're doing. I know we'll go into a lot more detail, but meeting people where they're at by bringing kind of really comprehensive collaborative models of care that have a really great evidence behind them, with just like basically like what is good clinical practice, and really shoehorning it within the healthcare system has been part of the innovation here.
Yeah, that makes a lot of sense. In retrospect, it seems so clear and obvious that this need exists, like these incredible wait times, the sheer number of people that are impacted by dementia, from loved ones to colleagues and coworkers and everyone in between. Question for Julius: was there a moment that really pushed you to act on this and leave your consulting job that sounds like you've been doing for a while and had great success with, to say, this is the timing is right to do this? It's sort of now or never. I mean, was it like a regulatory tailwinds? Was it a national kind of tenor towards more virtual care? Can you tell us a little bit about that?
I think all of these played a role, but ultimately it was that I was during the pandemic was doing a project for one of the national health insurance companies to roll out their digital health strategy. And as part of that, we were obviously looking for solutions in a bit of a hurry just to roll them out and get access to the population. And specifically, I was actually looking for a dementia care solution there, and there just wasn't any. That was, I think, sort of the impetus to say, like, okay, this is something that needs to exist. At the end of the day, then we tested a few landing pages and sort of saw that there was quite a bit of traction, that people were looking for this kind of care, not just payers, but also people directly. Then we sort of started, and then actually it was quite funny that people started reaching out. Like, for example, we had the chief medical officer from one of the national health insurance companies reach out through a Slack message on the Health Technology Nerds channel to say like, hey, I heard what you're doing. Like, I'd love to talk. And so that's how these things really emerged. It's funny that actually quite a number of our first payer clients we got sort of through proactive outreach, just how people heard from us.
You guys seem like you bring complementary backgrounds, and yet like you're both physicians, but have a different lens on this. What is it about your backgrounds that you think really complement each other? Maybe Joelle, I'll pose that to you.
We're a good match. I mean, we've been working together for, it feels like years and years and years and years and years, because it's like every waking moment. We finally gotten to a place where it's like we basically have an extension on our own cerebral hemispheres. Like, we kind of know what the other person's thinking. It is nice that we're both physicians, so we have at least a foundational level of understanding of health and healthcare. The way our Venn diagram kind of works in our kind of co-leadership model is anything that's much more very specific, clinically oriented, clinical questions, clinical model, where things are moving within the field. Those are more clearly my area. And then because of my research background, things that relate to understanding like epidemiology, population health, data science, that also falls within my realm. Whereas with Julius, his background is a really nice complement, because his background at McKinsey and other experiences that he had, he's able to like really think about like, what is it that payers want and need. He really understands the ins and outs of like how the health system works and how it doesn't work, and where the value proposition really is. And he's also able to do the things that like you don't learn like in residency, which is like doing really great modeling and forecasting of kind of what to expect over time, and really put together really nice McKinsey level kind of like presentations that really articulate the main point that you're looking to present, and beyond kind of like the clinical piece. Because I think if you work within a hospital system, you can think about any kind of quality improvement effort, right? But if you're not able to articulate it in a way that makes sense within the context of the business, it's going to fall on deaf ears. It's just going to seem like a charity project, to kind of put it crudely. he and I work really well where we have this kind of like really healthy tension where I'll lean more toward kind of just like, let's get the clinical care to people's hands. And Julius is like, okay, but let's make this like a really workable business model that's compelling.
You've talked kind of, I guess, at a high level about the goal that you're trying to achieve and the benefit you're trying to bring to people. And then you touched on that idea of, hey, it's tough to shoehorn best medical practice into the existing healthcare system. And so that implies to me that the conventional healthcare system lends itself to gaps. And I guess, do you have a sense on what specific gaps are there in, there's this difference between what the conventional healthcare system allows and what best medical care is. And it sounds like you guys are trying to bring best medical care, but what are those gaps that you're filling? And what have been the innovations in payment models, both under Medicare and private payers, that you think have enabled you to fill those gaps and make a solid business case to do it?
One of the fundamental challenges with dementia is that it really spans the medical aspect and the social care aspect, right? And that really historically have always been two very different funding sources. Medicare or commercial insurance pays for the treatments and the diagnosis. Then it falls really flat when it comes to the long-term care and support. Medicaid or private payers have obviously, or as like people themselves have usually picked up the bill on the sort of ongoing care, like getting home care, getting additional supports. And that's obviously just as important and critically important, especially to keep these patients in their home, well supported, and sort of out of hospitals and emergency departments, because that's usually the worst place for a patient with dementia to be. That is, I think, the fundamental problem. And I think Medicare has put forward a great new model recently with a guide model that actually merges some. I would say it's an early attempt at merging some of these funding sources and aligning the incentives here. And so it's a single payment model that covers both aspects. But obviously, there's a far way to go in terms of designing more value-based models here, in terms of actually measuring outcomes in cognitive health and quality outcomes. I think there's a lot still that needs to be developed and standardized. I think here at Isaac Health, we are really at the tip of the spear of innovation here and working with Medicare Advantage plans and Medicaid plans to actually devise some of these quality metrics and outcomes and value-based care models. But obviously, it's work in progress.
What have you found the overlap from this to be between the structure of that model and really what you set out to do, or what you think the ideal sort of blueprint looks like for Isaac Health? I'm just curious if there are additional services that you think are really important that are not included, or if that shape of that legislation really kind of checked all the boxes.
I think the guide model is a payment model, right? I think that we've always got to be clear about that. It pays, I think, for the full set of services that we offer. And in that sense, it's a really good fit. We were obviously doing this kind of care model, comprehensive dementia care model, long before the guide model was even discussed or published or was a thing. And so I think it was a convenient fit. But what Isaac Health does in addition is really to take that payment model and turn it into a clinical model that's really effective. And specifically, so the Isaac specific special source really is in scaling that specialist care, and also sort of really then supporting the members to stay independent. We've developed, for example, a whole compensatory skills training program and similar strategies that really add the value and really help support this patient population in a way that the guide model stays more vague and loose on.
I think the guide model is a really important and historic start to addressing these gaps that we have in the health system. I think the elements that are missing from it, just at a practical level, just thinking about the health system as a whole, is there's a whole other patient population that's being missed from the guide model. So there's people who have mild cognitive impairment who are likely to convert to dementia, who would benefit from having some additional supports and services and a comprehensive approach earlier on to be able to kind of have a really strong impact on long-term trajectory of the individual. And right now, the guide model is very focused on mild, moderate, and severe dementia. The other piece of that for other health systems is the feasibility of implementing it. I think it's something that I hear more and more from people who have tried to develop the guide model. I mean, that's basically like academic medical centers. I've heard many of them had applied, came into the established track and then decided to just forego doing it because they just couldn't make it work because it is quite involved and the payment model starts to align incentives, but the actual reality of it is that the compensation from it for systems that the revenue doesn't necessarily support how they typically deliver care. And I think that's part of what Julius and I have built here at Isaac with our whole team is creating a system that is able to provide that very comprehensive collaborative model that can scale and is able to make use of these types of funds. But we're also able to replicate that within a lot of our partnerships and saying, this is kind of like the ideal kind of care. And this is how we want to work with you to make it accessible to more people.
In your explanation, Julius, you talked about part of your secret sauce being the access to specialist care and at scale. And I'll say, anecdotally from my days in practice, that could be really tough to do. How are you guys doing that? Is that just through, you've got training programs, you've got good networks? Is it a technology solution, or is it something completely unrelated?
The key here is in the technology. There is really a lot of sort of smart workflow management, guidance, and really, I would say, sort of hand-holding the clinician, if they are non-specialists, to be able to provide specialist care and sort of really extending the reach of the limited pool of specialists that we do have. That is, is where technology plays a huge role and where I think we've got a great model at Isaac Health now that works really well to scale specialist care in a highly effective way. And that can really scale sort of infinitely to cater to the full population.
Am I hearing you right? Is it a interface between primary care providers and specialists primarily, or where does that sort of scale point happen?
Yeah, I think we have different care models. I would say the default care model is really that Isaac Health provides the full set of services and we provide everything through our platform.
And then I've heard stories about waits for initial intake. In terms of the neuropsychiatric testing and the sorts of rigorous cognitive measurements that need to happen in the beginning phase, do you guys have a solution for scaling that as well? It may be hard if you live in a rural area to find a specialist who's ready to administer a battery of tests.
Yeah. So for the neuropsychological testing, our system is pretty standardized. And so what will happen in a lot of health systems is that if somebody refers for neuropsychological testing, they'll see a kind of a neuropsychologist, a licensed kind of individual, and then they'll usually have the same backlog that the behavior neurologist will have. So you're looking at many months before you get evaluated. We have a pretty good system where we have psychometrists who are able to administer the battery of tests. So this is kind of a lesser skilled, non-licensed, but certified group of staff. We also have an algorithm that helps to guide which assessments to conduct and when to help to minimize burden for the individual. So that way we're getting only what we need for the clinical evaluation. I think there's a lot of solutions out there that are kind of like AI based or use augmented reality or VR and games. And there's just like, they've been developing these things for decades now. And I think there's a lot of promise behind them. To some degree, you don't need to do all that. And oftentimes what most health systems and payers really want is the reassurance that it's something that's really well validated and very practical. And on the patient side, you don't really meet them where they're at, then you might miss the mark. And for a lot of these patients, they might not have access to internet, right? That's like the key thing or any technology. And so having an app that they can download doesn't really work for them because they have like a hard time navigating an app. And it's not because they're cognitively impaired. It's because they just don't have access to those resources. It's just not part of their day to day. And so we've kind of created our network of psychometrists and we have our own AI-based kind of algorithm around the testing to make it much, much more scalable.
What kind of outcomes or metrics are you optimizing for? I mean, what's your benchmarks for success? Or put another way, what outcomes are you proud of to date that you've achieved that kind of reflect the steps you're taking towards that?
So there's definitely some clinical outcomes in terms of stabilizing cognitive decline and also helping patients with their neurocognitive goals. But then where we've invested more time is really to measure those slightly harder outcomes of, for example, ED admissions. We've seen a 38% reduction in ED admissions within 4 months of participating in our program. Also, a 28% reduction in hospital days. So those are sort of where you really see why a payer would be interested in managing this population better, because you can really see significant outcomes. But then beyond those metrics, there's a wide array of additional outcomes that we do monitor. Joel, I don't know if you want to go into deeper on those.
One that I'm pretty proud of just speaks to how hard it is to actually scale this kind of care is our operating margin. Making sure that, we're able to function in a way where there is still some revenue left over to be able to continue to build and kind of compensate people properly and kind of scale the operation. I think that's one of the things that's made a lot of health systems really leery of this kind of care is if they operate on a negative margin, then they're just going to see it as another cost center. And then you go into this death spiral. For us to be able to have a pretty healthy operating margin really makes sure that we have a really compelling argument for building this out and continuing to invest within kind of what we're building here so we can reach more people.
I know that since your focus is on patients and caregivers ultimately, and you're really bringing care to folks, curious just to hear the sort of feedback and stories you've gotten from patients and caregivers. Is there anything that's particularly memorable for you, for the two of you, that's really propelled you forward?
Quite a few of these situations. I think just generally a lot of the time I'll hear the patients and families, they'll bring up their care navigator a lot. The care navigator is really kind of the heartbeat of the work that we're doing. They're their main point of contact. They know all their care navigators by their first name, and it's very common that they'll get into tears just to feel that they have that kind of support and access to someone who can help to guide them through a really complex situation. People really love kind of how prompt we are, how everything is under one roof a lot of the time. There's stories that we have that I think really, really stand out to me are like the patients and family members where they hear about what we're doing and they'll say something like, we thought this was using an expletive. Like we thought this was all like a bunch of hooey. But now that we're saying this is like, I can't believe that this is real. And we've had situations where just having a home care aide come to the home to help facilitate the visit has identified people like who are in really dire straits, from both like husband-wife couples where both of them have dementia that's progressing and they don't have any supports. And so that's like a real recipe for disaster, to coming to the home and finding that someone was down at home, delirious because they had a big medical complication, and be able to get a wellness check and get them to the emergency room and give life-saving interventions. I mean, I think it's really, really powerful what you learn when you're actually going into communities, really coming to people's homes, which is something that, having been within hospital systems for all of my clinical career, you really don't see it because they usually, you only see the people that come to you.
Pretty powerful and compelling testimonials there. Julius, Joel, thanks so much for sharing your work with us. You guys are tackling one of healthcare's biggest problems, and I think it's safe to say everyone's rooting for you. And we'd love to see this scale. Best of luck with all your efforts. And that'll do it for today's episode of HealthTech Remedy. Don't forget to subscribe, rate, or share the show. Thanks again. Looking forward to seeing you guys next time.